We're going to be talking about anxiety and obsessive-compulsive disorder, which now has a new name, and comorbidities that they have. In other words, similarities that they have or commonalities that they have with autism spectrum disorders. So as I've said before on this show, in May of this year, we had the new diagnostic manual come out, right? DSM5, Diagnostic and Statistical Manual of Mental Disorders, number 5. And up till May, we had the DSM-4, and the DSM-4 was, very straightforward in terms of how we defined anxiety. So I've kind of put that on the screen first because I want people to be able to see that in DSM-4, what we had was basically, 7 disorders that were listed under the heading of anxiety. There was a chapter called basically anxiety disorders, and they were listed as panic disorder, separation anxiety disorder, specific phobias or fears, social phobia, obsessive-compulsive disorder, post-traumatic stress disorder, and generalized anxiety disorder. And that had been that way for many, many years. I mean, I don't even remember the first time I was trained on that, maybe 20 years ago. I don't think there's been a change in the anxiety chapters for a long time. This year now, with the DSM-5, there's been a huge change. So in general, there have been more changes to the DSM-5 than any other DSM, I think. Like this year, they really have changed a lot of things. So what I did was I went through 2 chapters. That's why this presentation is a little bit longer, because we're going to talk about the chapter on anxiety very briefly. And what they've done is they've taken obsessive-compulsive disorder, because it is so important and it is becoming so prevalent, that they've given it its own chapter. And it is now called Obsessive-compulsive and Related Disorders. So I'm guessing pretty soon we'll be calling it OCRD. And it has its own subtypes and its own features, and so it has been separated. They have now also separated and given its own chapter the post-traumatic stress disorder and similar types of trauma-related disorders. And actually, I don't think I have any slides on this at the end of the talk, but I will briefly mention a couple of disorders that are listed under the PTSD, the trauma-related section, because you'll find them very, very interesting. So right now, what we're going to do is we're just going to briefly look at what is considered anxiety in the DSM-5. And the reason I say briefly is because even after we go through the anxiety chapter, it's repeated multiple times, first in the anxiety chapter and then in the obsessive-compulsive and related disorders chapter, that there is a huge overlap or comorbidity between obsessive-compulsive behavior and anxiety. So let's repeat that again, because that is the critical aspect of how we are defining and seeing anxiety. I'm going to talk about that a few times. When you obsessive-compulsive disorder, essentially, once we get into that, you'll see, but it consists of obsessions or thoughts and compulsions or behaviors that help reduce those obsessions. And the obsessions are usually very, very similar to anxiety. So they're like the same type of stuff that happens when you have anxiety. And that's why it was classified as one of the anxiety disorders. So right now in anxiety disorders, and I'm going to go through these because some of these might sound similar to things that your kids are experiencing. We have separation anxiety disorder. Obviously, a lot of our kids have a hard time with separation from the parent. Selective mutism. Selective mutism is when the child chooses not to speak. It is not the same as autism. I don't want people to go through and think that I wonder if my child is choosing not to speak. With selective mutism, it's usually the child has been speaking for quite a while, and it's environmental. So it's specific to some environments. Like the child will just not say anything at school. And it really has a lot to do with their fear or anxiety of the environment. And then we have specific phobias. Specific phobias are obviously fears of various things. I have had many children who've gone through like different fears, you know. So they'll initially they'll be afraid of, let's say, water, and then they'll be afraid of the dark, and then they'll be afraid of various other things. And specific phobias are really very easy to get through, but they are kind of common in our kids, and you do see some of that. And then you have social anxiety disorder, which is obviously, just by the name, you can tell that this is something that's pretty familiar to our kids. So this is where the child feels very anxious in social settings, doesn't want to approach social situations. And quite honestly, Shannon, this is one where you could say that a lot of people in general have social anxiety disorder, where you don't really want to go to social settings because it makes you very nervous. Now, as I'm saying this, it occurs to me that I should make one thing clear, which is nothing is considered a disorder unless it impacts your daily life in a negative way. I mean, there's a very specific definition of this. And basically, I've used this example in the past where I've said, I could go home and drink a bottle of vodka every night, and as long as I was good to my family and went to work and was a responsible adult, I would not be considered to have alcohol disorder or any kind of alcoholism. So this is very important because some of us have social anxiety. A lot of people have social anxiety, but whether or not it comes to the point where you can call it a disorder has more to do with things like you're so anxious that you will not go out at all, and you begin to sort of stay at home more and avoid a lot of situations of life. And then of course that'll turn into, let's say, agoraphobia, where you're just completely afraid of going out. Or, as you can see from social anxiety disorder, it goes to panic disorders, the next one. And a lot of people will say, I've had a panic attack. And you might have had a panic attack, I don't know, maybe 5 times in your life. But people who have panic disorder very regularly suffer from panic attacks. And it is you actually see physiological changes, heart palpitation, and a lot of symptoms that indicate they're experiencing pretty severe anxiety. And of course, agoraphobia, as I mentioned, is the fear of leaving your home or going out, and that's a very common type of phobia. And it's becoming worse and worse, and it is very much related to anxiety. And then we have generalized anxiety disorder. And generalized anxiety disorder essentially means that there are more than one situation that causes you have a generally high level of anxiety on an ongoing basis. There's a lot of people with generalized anxiety disorder. This one is the hardest to diagnose because it is you kind of come to know the person as that, and you don't identify that they're more anxious in one environment or another because they're just generally always anxious. And what's interesting is the last 4 are a series that are have been added to a lot of the new chapters in the DSM, and all of it shows how our thinking has changed. So the next one is substance or medication-induced anxiety disorder. And that means that you might be taking medications that are causing you anxiety. And when I start to talk about autism a little bit more, you'll see that is one of the points that I brought up, is that we don't realize that there are a ton of medications that our kids take that actually can cause anxiety. Not even just medications. If you think about it, our kids sometimes are taking, let's say, vitamin B. Niacin, which is a form of vitamin B, gives you sort of a little rush. That's the vitamin that gives you makes you all tingle.
It's a flush sometimes.
It's a flush, exactly.
Yeah.
And that, for little kids, can provoke anxiety.
Sure.
So there's a lot of medication that can sort of induce the symptoms of anxiety. Then the next one is anxiety disorder due to other medical condition, which is awesome that they have this in here now, because as we go into talking more about autism, I'll I'll mention several different things that actually cause anxiety or other types of problems and disorders. One example being if you don't sleep. Right. If you have a sleep disorder, you are going to be anxious during the day. It's simply that. If you have any kind of, if an adult, for instance, has any kind of other addiction, it's going to result in anxiety. So there's a lot of other medical conditions that will lead to anxiety. And then they have the two last categories, other specified anxiety disorder, in other words, an anxiety reaction to some specific thing, or unspecified anxiety disorder. And those last four have been added to all the new chapters. So when we go into obsessive-compulsive behavior or disorder, you'll see the same sort of substance-induced OCD and OCD due to other medical conditions. It's kind of like it shows the, I guess, the open-mindedness of the new DSM-5 in terms of, everything that we suffer, of course, we're whole human beings, is kind of interrelated. One thing causes the other, and so you could have other medical conditions that are causing your problems. These could be causing other issues, and so on. So that's just what we're trying to say in the DSM, is that a lot of what goes on is related to each other.
To me, it seems like a very common sense approach to it. I mean,
absolutely.
As parents of kids on the autism spectrum, we know our anxiety level goes up just from our child having a diagnosis. And I think of friends who've been diagnosed with cancer,
right,
and they not only have to deal with the cancer, but they have to deal with all the anxiety that comes with all the things that are going on. It makes sense.
That's exactly right. And if you think about it, that's a great example, because I would say that, something like, for instance, other specified anxiety disorder could be something that is, induced by having a child who is ill or has a disorder or something like that. Then that would be classified as other specified anxiety disorder, unless it caused you panic attacks, in which case it would be specified as panic disorder, or so on and so forth. So what I'm trying to say is there's a lot of overlap. And one person could go from having, let's say, separation anxiety disorder to agoraphobia or to panic, and so could overlap on more than one of the ones listed here.
Okay.
Now we're going to talk about sort of what do they have in common. What is anxiety all about, really? Anxiety disorders in general are disorders that share excessive fear and anxiety. Okay, so they all have a component of fear and anxiety. Fear is defined as the emotional response to real or perceived imminent threat. Anxiety is the anticipation of future threat. Now, there isn't really much of a difference there. I mean, if you have an emotional response to real threat or imminent threat, it's very close to being fearful of the anticipation of future. Anxiety just kind of lengthens the time frame. In other words, fear is sort of what happens after, just before an event is about to happen, or just before you think an event is about to happen that's scary. And anxiety is worrying about it for a long time.
Makes sense.
It's really that clear. So, and anxiety is usually about real life events. And I'm going to put this in there because you'll see the differentiation a little bit later. So it's important to identify that it doesn't necessarily have to be actual threat that's coming your way, but it is not imagined or fantasy. What anxiety is usually about something that we think is going to happen, and it's possible that it could happen. It's real life. It's not like Martians are going to come and take me. Okay. Although, who knows if that's real? So I'm very open-minded.
Good point.
So, and the most important of all is to say again that there's great overlap between anxiety disorders and this new category or new chapter called obsessive-compulsive and related disorders. In fact, there's a 76% comorbidity. That means that 2/3 of people who have anxiety have the other or the other way around. There's a huge comorbidity. So really the only reason that I can imagine that they took OCD out of the anxiety chapters is that it is such an important disorder that it needed to have its own heading and its own chapter, and we will go into that in a minute.
Okay.
And the difference is that obsessive-compulsive disorder is usually somewhat irrational. It's somewhat more fantasy type related, or stuff that, most people would say, this isn't real. It can't. So the thing that you're imagining, for instance, being covered with germs, okay, is irrational. You have not been exposed to germs, and you have an irrational belief that you are covered in germs, or you have an irrational belief that some other thing is going to occur, and that's what you're obsessing about. So there's a slight difference there, that anxiety is usually real life situations, and OCD has to do with more things that are a little bit less rational. Although, having said that, I think the next time the DSM comes, they're probably going to remove that distinction, because I can think of a lot of people I know with anxiety where their fear becomes pretty irrational. But I think what they're trying to do is they're trying to make us understand that, you know, and this is how I see it. Like, when you have a very, very high level of anxiety or worry or fear about something, it will ultimately lead to other things. It'll either cause you to do compulsive behaviors, which is OCD, or it'll lead to physiological things like panic attacks, or it'll lead to avoidance completely, which is like agoraphobia. It leads to some sort of behavior or defense or physiological response because it's so overwhelming to the individual who's experiencing the fear that it perpetuates. That makes sense.
Makes great sense to me.
Okay, so the next slide, we are now going to start actually talking a little bit about obsessive-compulsive and related disorders, and then I'll show you what they are, and then we'll maybe see if there are any questions we need to answer. We can keep going. So as I said, the new chapter, now we're going to really focus more on this section, because this is where it relates to autism. It's called obsessive-compulsive and related disorders. So I wonder if they're going to change us now from OCD to OCRD. Very likely, because ADD became ADHD, if you remember.
Yes.
So the obsessive-compulsive disorders are characterized by the presence of obsessions and compulsions. Okay. Obsessions are recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted. Compulsions are repetitive behaviors or mental acts that an individual feels driven to perform in response to obsessions. Okay, so many examples. You know, I'm afraid that I'm dirty, I will wash my hands 100 times. I'm afraid that I left the fire on, the stove on, I'm going to go and check it 100 times. But I highlighted the word repetitive behaviors because this is where you start to see some of the similarities with autism, in that it's, in fact, when you, I love the DSM for this, but when you start looking at the obsessive-compulsive chapter, there is a page and a half about the similarity to autism. Okay, now, good. And there's a lot about how the behaviors are similar yet different, and how you can try to differentiate, but that there is a huge overlap. And we are beginning, people are beginning to understand that there is a very big component of OCD within autism. It's not listed there, it doesn't say it's there, because the way that the DSM functions, it's sort of like, I've said this before, you know, when something is a little bit more pervasive and could lead to a multitude of symptoms, you just, you go with that label. It's kind of like saying someone has pneumonia. So if you have pneumonia, obviously you're going to have a cough and, you know, difficulty breathing and possibly a fever and so on. But you're not going to get a diagnosis of, let's say, pneumonia and bronchitis, because pneumonia is kind of more overriding than bronchitis. And with autism, the expectation is that it is more pervasive and that it will influence and affect the child in a multitude of ways. So, you know, people don't go into identifying the other types of illnesses or problems or disorders that the child or individual might be experiencing. And I actually think it's very important to do that, because first of all, funding agencies sort of depend on knowing that. It's one thing to say a child has autism, it's another thing to say the child has autism as well as anxiety or OCRD, as well as, let's say, panic attack or panic attacks or disorder, or selective mutism. That's a great example. If I have selective mutism going on, it's going to require a lot more work.
Right.
And so these things are actually important to add on and not to be considered part of the autism diagnosis. I'm going to go into that more.
Because we don't want to just assume and say, well, because restrictive and repetitive behaviors are part of autism, I know that sometimes people just accept and go, well, that's autism, as if there's nothing we can do about it.
Exactly.
And that is false.
That is false. I mean, it's not that it's false. It is definitely a part of autism. It's one of the symptom criteria that leads to the diagnosis of autism. But just like anything else, it is treatable. Just like anything else. I mean, we look at these disorders like obsessive-compulsive, and I'm going to talk about the treatments. Well, clearly with autism, it's the same thing. And the way to treat any disorder is to break it up, and look at its individual symptoms and try to deal with the individual symptoms. Now, there are some where we don't know very well how to control them without medication, like let's say schizophrenia. But nevertheless, schizophrenia, of course, the best treatment is still medication as well as therapy.
Okay.
So, and that's always the case. Pretty much anything I've ever studied, the best treatment is the combination of medication and some sort of treatment, therapeutic treatment. We're going to talk about how to treat some of these and the medications that help as well.
Would you like to take a break?
I think I'm going to.
Or wait?
Just see. Sure. If there's,
okay.
Let's take a few minutes.
Let's take a short break because I don't want to work you into the ground.
Okay.
This is a lot of information, so we're going to take a short pause, and we'll be back more with Dr. Doreen Granpeesheh. This is the Anxiety Show. Stick with us. Welcome back to Ask Dr. Doreen. We're here with Dr. Doreen Granpeesheh, and this is the much requested show, the Anxiety Show. We should say it's the first because we're planning on this taking more than one show because we want to take our time. This is a very important topic, as you were saying, because it so affects our community.
Right.
And I think primarily we're really interested in knowing about how this affects our kids, but the secondary is that it affects the parents as well.
Oh, absolutely. Yes, our parents have a lot of anxiety generally.
Well, I can speak to that.
Yeah. No, it's not. It's not hard to develop anxiety symptoms when you have a child you're worrying about all the time.
And knowledge is power, and understanding how these symptoms come about and what to do about them is a powerful, powerful thing. So Dr. Granpeesheh is here today talking about this with us, empowering us. We thank you for that. We went through some of the differences between the DSM-4 and the DSM-5 and how these things are categorized. So where would you like to pick it up now?
Well, we're going to talk, now we're going to just continue and talk a little bit about the obsessive-compulsive and related disorders. And then I will just start going into how they relate to autism as a whole.
Great.
So
we need to tap the screen here.
Oh, okay.
Okay, there we go.
Okay. So the obsessive-compulsive and related disorders are listed below, and I highlighted in red the ones that I find to be very commonly seen in ASD. For instance, and we'll go through them, obsessive-compulsive disorder, which I will go further into. Essentially, as I said, obsessive-compulsive disorder is, having obsessive thoughts about something and then doing compulsive behaviors to try to reduce those thoughts. Body dysmorphic disorder is one where you actually have different, you obsess about various aspects of your body. Okay, very simple.
Could result in anorexia? Or
it could absolutely result and develop into anorexia or other types of, people who, for instance, have a lot of plastic surgery or various other things.
Okay.
Hoarding disorder is where you carry around or you hoard objects. So in other words, I mean, we've all now seen these shows about hoarders and people who will not throw things away and they will keep them. And what the general public doesn't realize is that this is actually a form of anxiety because it shows that the individual is so afraid that they are trying to sort of, surround themselves with things they own that will help them feel safer. It's always an obsessive thought, a fear related thought, and then a behavior which helps reduce the fear. And in hoarders, it's keeping things around them. Now, I've highlighted that because I know a lot of my children, will carry objects, you know, so they will, for instance, you'll see that they'll have a couple of objects that they carry together, and a lot of my kids will have like a little drawer or a little place where they put all their stuff, and they don't let anyone touch it because it's my stuff. And it's, or, you know, very basic form of this is carrying around your blanket all the time, and it's not really hoarding, but it's the same concept as this object is necessary for me to not feel anxious.
And going back to what you were saying about the panic, all the things under the anxiety, you know, someone might be listening to this and think, okay, well, you know, my garage is a mess, but that's different than, it has to get to the place where it's disabling to your life.
It's extremely disabling.
Okay.
Yes, it's not really. I mean, you know, we have opinions about who throws enough away or doesn't throw. There are some people who throw everything away, other people who don't throw anything away, but hoarders, again, it becomes debilitating.
It's another level.
Right,
okay.
Absolutely.
With all of these things, it has to be at a certain level that it's preventing you from leading the life that you could lead.
Exactly.
In order for it to be classified as a disorder.
That's correct. And then we have trichotillomania, and trichotillomania is pulling out hair. And, you know, I knew someone actually who had trichotillomania, and they were constantly, it was a man, and they were constantly pulling out hair from their beard. And it's an anxiety type of habit, you know, and it's just, you're just pulling out hair. I don't know if you've ever seen that.
Yes, it's a very interesting disorder.
It is. And again, it's as you notice, the commonality with all of these is, you know, the obsessive or the anxiety feeling, and then the repetitive behavior. Remember, that's how we defined it. It's always an anxiety feeling and then the repetitive behavior. So it's kind of interesting. Excoriation disorder is picking skin when you're anxious. And as you know, a lot of our kids do this, so I actually highlighted that as well. And so it's important to note that when you see these things, start thinking about, well, what does it mean if your child is actually from anxiety, for instance, picking skin? Now, this is different from, let's say, a child who might have a injury. Right. If you have an injury, it's very common for us to try to pick the skin. That everybody does that. I did that when I burned my hand. But that's not the same thing. And here we're talking about people that I mean, if you have excoriation disorder, or if you've seen someone with this, you know what I'm talking about, because it gets to be very, very difficult to control.
Yes.
And this is really just because it's a repetitive behavior. And it's, as I said before, somewhat irrational. But it is something that you do, and unless you do it, you're going to feel anxious.
Yeah.
Okay. Then we have, of course, substance and medication-induced OCRD, or obsessive-compulsive related disorder. And I'm going to go more into when I talk about autism, but there are a number of medications that can be increasing the anxiety that our kids experience.
Would PANDAS come in to play, or is that an entirely different thing?
Very different thing.
Okay.
PANDAS is sort of the pediatric autoimmune neurological disorder associated with strep, PANDAS. And that is a series of kind of problems and issues and delays that come about if you have had strep infection at some point, and it has led to an autoimmune reaction, which has led to neurological problems. Okay. And that is, you know, one of the subsets of autism, and it's easy to diagnose actually, because well, I mean, first of all, it's surprising. You'd be shocked how many people don't even know if their child had exposure to strep. You don't necessarily have to have seen the symptoms of strep. So a strep titer is done to identify that. But the second thing is that usually with kids who have PANDAS, it was a sudden decline. So it was kind of like the child was progressing, and then at some point there was a sudden drop. And it doesn't have to be the early years. It could be later as well. Okay. So that's a little bit different. But, you know, substance and medication-induced stuff is like you're taking, let's say, medication for ADHD, and that will automatically cause some level of anxiety because it's an amphetamine. Okay. So, you eat mass quantities of chocolate or red dye, substance-induced. Okay. So a lot of the stuff that we eat in our food could be increasing our anxiety levels as well.
Interesting. All right.
Yeah, that's where
Very
the dietary
interesting.
stuff comes in.
Yeah.
Other specified and then unspecified. Now, as I said, that's pretty much in every chapter now. But what I liked about the unspecified obsessive compulsive and related disorders was that they listed a few, and one of them was body focused repetitive behavior disorder.
Wow.
Body focused repetitive behavior disorder. So we're talking about...
Yeah, we both automatically start to rock.
Right, so we're talking about certain repetitive behaviors that are just within our body. Now, this is fascinating to me because, and I'm so glad I came into the field of psychology because I should have been nowhere else. Like I'm telling you, when I pull up the DSM, and I start making presentations about other stuff, and I am in there for 6 hours. Like I just don't even want to leave. This is very interesting because I remember I have known people who are not at all on the spectrum of autism, and in fact extremely intelligent people, and not at all in any way hearing impaired or anything else that could lead to this kind of body rocking, but they do when they're anxious literally body rock.
Yeah.
So there are people who do literally do that just from anxiety. In our kids you might see that, you might see a lot of and it's funny because with our kids anxiety and excitement are very difficult to differentiate, obviously, and so when you see our kids very excited, they'll do this as well.
Right.
And if with little children in general, not just kids on the ASD spectrum, but just little kids in general, they'll jump up and down if they're excited as well as if they're anxious, like when you're fearful and so on. So the commonalities between the obsessive-compulsive disorders are that here's some different aspects of them. So there's the commonality, as I said, is always there's some obsession and then there's a compulsion. So these are the different types. A cleaning OCD, which means there's contamination obsession and then cleaning compulsion. A symmetry type of OCD. So that means there's an obsession about things not being in perfect order, symmetry, and then there's a repeating or ordering compulsion, and that's the one that you see the most in ASD, where I think we even had some questions on this, where you see a child will put things in a particular order, lining up objects, their toys and so on, or items, and getting very, very upset if you change the order of the objects or if you destroy the line. So this is actually a very common thing, and it's not just in putting things, not just in tangible order, but it can be stuff like there's no symmetry because you're taking me to school from a whole different direction that we usually go. There's no order. Doesn't make sense because we've never done this before. So change.
And inflexibility.
Inflexibility. That's exactly the word. It has to be this way. It's the things have to follow a particular sequence, and if they don't, it's the end of the world.
We actually have a question having to do with this. Do we want to wait for that towards the end?
Sure, we can throw it in right here.
Hi, Shannon and Dr. Doreen. Thank you so much for discussing a very important topic. My daughter is 8 and was diagnosed with autism when she was 3. She likes to keep things in their places, like toys and bags. She also likes to close open doors and zip up bags. She gets upset if we change the places of the toys or backpacks and insists on putting them back. If the bathroom door was open, she runs to close it and gets frustrated and bites her hands if we try to block her. What is the best way to manage these behaviors? And we appreciate Dr. Doreen's feedback in advance.
So we're going to talk a little bit about how to treat these behaviors later, probably more next week. So please stay tuned with us, because if I jump into that, I'm going to kind of go heavily into the...
Absolutely.
But the thing is that, I want people to think about it this way. Like if someone is blind, okay? If someone does not have the ability to see, they will, how do they manage in their home? They place things in a particular place, and they don't want things moved. And the reason for that is so that they know where things are, right? Because they can't see them. So they know where things are, so they can depend on things being where they left them, and that's how they function in the world.
Right. Okay. It's a great coping mechanism.
It's the only way that they can cope. Exactly. So now think about it from an autistic person's perspective. Things are placed in a particular way because they receive. Now it's more irrational, obviously, because you can see as well to some extent, and who knows how well our kids actually have visual skills, but some of our kids. But it gives you a sense of control. Having things in a certain order removes completely the surprise element. There is no surprise involved. So with your child here, there's no surprise, and she wants, and you know, everything that this parent listed has gone to an irrational level or to an excessive level. But if you reduce it, then you can see how it developed. It's like, okay, so what were they? She places things in an order, I think.
She likes to keep things in their places, like toys and bags.
Right.
She also likes
so that she knows where they are.
Right. She likes to close open doors.
Right, because that gives her a sense of safety. Now, keep in mind, we're always talking about behaviors that reduce fear, reduce anxiety.
And zip up bags.
Yeah, so that they remain orderly or clean or whatever.
She gets upset if we change the places of the toys or backpacks and insists on putting them back.
And then she gets all worked up and bites her hand and so on. And as I've said multiple times, biting and those types of behaviors is simply communication. She's trying to say, don't do this. It upsets me when you change the order of things. And I don't want anything changed because this is the only way I feel safe in the world. Very simple. So you understand the cause, you understand what's making her feel that way, but you don't want to really reward the fact that she's biting her hand every time. So that still means you behaviorally intervene, and you don't necessarily stop doing what you're doing every time she bites her hand, because then you would be rewarding the hand biting. But it's always important to understand the reason. Remember, we talk about the function. One of the things we're writing a book right now, and I kind of want to be brave and write a new thing about how we talk about the function of things being, the function of behaviors are always like to avoid something or to gain access to something. And one of those key things in my mind is to avoid or reduce anxiety.
Absolutely.
A lot of what we do in our world is just to avoid anxiety. A lot of what we do, honestly. If you think about it, something as simple as alcohol, drinking alcohol has to do just simply with reduction of anxiety. That's all it is. What do they say? It reduces inhibitions, which means it reduces fear. So, and because I'm one of those people that believes life is about fear, like overcoming your fears, that's why we do all the different things we do. Now, with this child, it would be important the reason it's important to know why the behaviors are occurring due to anxiety is because then you can help the child overcome the anxiety. And that's where you focus your attention, is doing things that will help the child overcome the anxiety. And there are many things you can do, medications being one, and we'll go into some other cognitive behavioral treatments as well.
Okay.
So now with the OCRDs, the other two, forbidden or taboo thoughts and harming self, or obsession about harming others, is stuff that we don't very commonly see in our kids. So I'm just going to try to skip over those and keep going. Okay.
Do you want to take a break?
No, I'm going to keep going because we don't have very much time left.
That's
and then
true.
Next week we'll go heavily into the relationships. Let's just see where we are now.
Okay.
So one of the really important things, I know a lot of people will ask this question, is that, when you look at first-degree relatives of an individual who has obsessive-compulsive behavior or disorder, so that means, first-degree relatives, so child-parent type relationship, is the rate of obsessive-compulsive related disorders is double in first-degree relatives. So in other words, if you have obsessive-compulsive related disorders and I don't, okay, that's the normal relationship, but your child might have twice as much the likelihood of having obsessive-compulsive related disorders. Now here's the second point, which is more important. If you had obsessive-compulsive disorder as a child, then the likelihood that your children will have it is 10 times as much.
Wow.
Yeah. So that I found to be very interesting because, it is something to think about.
It absolutely is something to think about.
And and we don't know right now, we call it, it's under the heading of genetic components, but you don't really know if that's true, because I was thinking about this, and if you as a child have obsessive-compulsive disorder yourself, the question really is if you've gained control over that as you become an adult, because if you haven't, then it's possible that you would, your anxiety would then kind of affect your child's or your family members. So that's another, it's sort of a behavioral or environmental component of it as well.
I absolutely, I've shared before on the show that I have some of these things that we're talking about.
Yes.
I certainly have battled anxiety and OCD, and like a lot of moms who have children on the autism spectrum, I fully, go, yep, I have some of these things. And it wasn't until my son had autism that it got to a rate where I needed to seek out help. I didn't seek out help until I saw my son starting to engage in some of the behaviors that I did. Mm-hmm. And that was when I got my wake-up call, and I said, okay, this is not okay.
Yep.
I have to get help for this,
yep,
because otherwise I will have changed the way he looks at the world, and I just refused to do that. It was hard, but I got help.
Yeah, that's exactly right. It's so sad when you see, I go back and I think of some of my patients and also some people that I've known, patients outside of ASD, and it is really, really sad. I mean, it's pretty debilitating. I remember, first of all, I remember someone I knew who had their OCD had become extremely severe, mm-hmm, and it had turned into agoraphobia. They would not leave the house, and when you went to visit, she had gloves on, plastic gloves on, and a sort of a cleaning spray and thing, and that's how she lived from the minute she woke up. And it was extremely sad, not just to see what she was going through, but how it was affecting her. I think her daughter was maybe 14 or so at the time, and it was really causing, like, even to a level of psychosis for her daughter, because her daughter was must have probably been through many years of this. Mm-hmm. And it causes an ongoing fear, because you never really know when the person is going to react to you and blame you. Mm-hmm. I mean, I knew someone else who actually used to get very angry if someone had hair, a strand of hair that would come off, because it would freak them out that it's going to fall on the floor or something. Yeah. OCD can be pretty severe. Yeah. And then I remember a mom I had who wouldn't even come to our clinic many years ago because she felt that the world was too toxic, and so we couldn't actually help to see her child because she wouldn't leave the house, yeah, with her child. She wouldn't allow the child to go to school. Not because she was worried about the child, she was worried about the child bringing germs home to her. Right. I mean, it can be very devastating.
Yeah. I mean, I stopped driving. I was 40 whatever years old, and I stopped driving and pretty much had said that I was never going to drive again.
That's amazing.
And I was somebody who had always been a road warrior. I'm a road warrior again. I commute a great distance to come here every morning, but I had stopped driving for over a year. And so when we came to clinics, my husband had to be present. I mean, usually that was the case anyway, but he absolutely had to be, because otherwise we couldn't drive here.
That's amazing.
So, I relate to a lot of these things, but quite honestly, it got exponentially worse the more we got into autism. And I saw that, because I was going out less and less, to the point where, I pretty much the only thing I was going out for was to come here to clinic. And it was a day that my son, we had to go someplace, and here he is supposed to be having a social program, and he stood there and said, I want to go home. I want to go home. I don't feel right. I don't feel right. I want to go home, which is something that,
you understood.
I had said. I'm just keeping it real here. I had had said that to my husband, I just want to go home. I don't feel good. I want to go home. I want to go home. And here my child had picked that up. So it is essential that we all, it's hard. It was hard to face it. It was hard for my husband and I to face it, but because I didn't want anybody to help me with it, because I didn't want to drive again.
That's right.
Right. But you have to get help for yourself and you have to get help for your child.
Absolutely right. Right. That's right. And you made me think that instead of going into sort of this, I want to skip to another area where we look at anxiety in ourselves. If I'm going to leave people with anything this week, I want you to start thinking about, let me just see if I can find those slides. I want people to start thinking about anxiety in yourself, because when you understand anxiety in yourself, as you say, Shannon, you can really help to treat things and to help your child, help yourself. It's very, very important that you are able to come from that. How do we define anxiety? We define anxiety as a normal reaction to stress. It starts that way, right? It helps us deal with tense situations in the office, study harder for an exam, keep focused on an important speech, whatever it might be. In general, anxiety helps coping, okay? But when it becomes excessive, there's an irrational dread of everyday situations, it becomes a disabling disorder. That's how the National Institutes kind of views anxiety. And the truth is that when you study anxiety, I remember this many years ago, there's a curve that occurs. A certain level of anxiety is extremely helpful. If you don't have that, then you become lazy, you procrastinate, you don't care, you won't go and do anything, you just don't care about stuff. So a certain level of anxiety, people who have a small level of anxiety prior to an exam will always do better. But an excessive level of anxiety just makes your behavior fail.
So there's a window we want to be in.
You definitely want to have, you definitely want to have a slight amount of the ability to have some level of anxiety, and that's kind of important. Now, see, my slides are kind of out of order here, so it's hard to find the slide that I want to look at. But I want to go to the concept of helping you to find anxiety in yourself, and I've listed some of these things. So let me find that slide. Okay, here we go. What are some of the things that you call anxiety? And this is really important. Like, when you're anxious, some people, these are different things I asked different friends and they put this up for me. So I worry. I'm afraid. How do you define, like, when you're anxious, how do you feel? This is all I asked. Well, what would you say you feel? And these are what people said. I'm afraid. I don't sleep. Now notice how common that is. That's very, very common. And when you look at your kids, and I'm going to relate this to our kids when we come back next week, so many of our kids don't sleep, and we just ignore that. Sleep is one of the biggest reasons for a million different things that our kids go through. It's one of the most important things. I don't know how we can possibly be treating our kids without considering the amount of sleep they get. It's so critical. Some people will not eat when they have anxiety. Some people will eat too much when they have anxiety. So always notice that it's always a behavior change, Some people will just obsess and worry. Others will have racing thoughts. Someone said this to me, so it's kind of like you jump from one thought to the other, which is kind of interesting if you think about our kids not being able to focus.
Absolutely.
You can have heart palpitations. You can have things such as irritable bowel syndrome. So it does actually affect your GI system. You can feel dizzy. All right, these are some examples. And I just want to go through this slide as well. I know we're running over time, so I just finished this slide as well. And how do we deal with anxiety? Now, this is what's important, because you'll notice that people deal with anxiety in a million different ways. And when we come back next week, we want to talk about adaptive ways to help our children deal with anxiety instead of, they could choose non-adaptive ways.
Right.
So some people I'll distract myself. That's what someone said to me. I will keep myself busy. Okay, I will talk to my friends or gain reassurance. Well, our kids don't do that. They can't. I pray. Our kids don't have a concept of that. But praying, if you think about it, is sort of a repetitive behavior that comes out of reduction of fear. That's when people pray most, right?
Absolutely.
I take medications to help me. I exercise. That would be a very adaptive, healthy way to deal with it. I breathe, I meditate, I do yoga. So this is one of the areas that I'll talk about next week, what we can teach our kids. I practice positive self-talk. I try to change my beliefs. That's what I think more than anything else ABA helps our kids to accomplish, is that they actually start to learn that their thoughts are not rational. I try to change my beliefs. I avoid what's making me anxious. That can lead to complete avoidance, which is not good. I take drugs, alcohol, or I try to change what's causing me anxiety. So these are, and whenever you see the word change in behavioral terminology, that means shaping. So next week, what we're going to be talking about is behavior change and how do we make that change occur. What I'll do next week is I'll go more into sort of what happens in autism that leads to anxiety, and then we'll talk a lot about treatment.